So this time I'm going to discuss more of a little more in depth into some of the science behind what some of what I spoke about last time. So this talk is an extension and more detail of what I've already presented in some ways. If you have, as with before, if you have any questions, just throw them out there. This one probably will go a little faster because some of the slides are going to look the same, by the way, but it's for different reasons. So, biomarkers of Alzheimer's among Mexican Americans. In the last talk, I set the stage to really explain to you why I think it's important to study the disease separately by ethnic groups. And our work focuses largely on working with the Hispanic community in the Dallas-Fort Worth area, largely within Texas, Mexican Americans. And my other area of work that I've been pushing for quite some time now is biomarkers of disease. So now what we're doing is merging those fields, and I'm going to kind of walk you through that. This is the same disclosure that I presented earlier, that we're funded by NIA, EPA, State of Texas, and there's a patent pending, and another patent going in regarding an Alzheimer's blood type. So this time what I'm going to discuss, I'm going to discuss why blood-based biomarkers are important in Alzheimer's disease. I'm going to discuss what we've done previously, and then what are some of the implications of our more recent work. So, blood-based biomarkers in Alzheimer's disease, what's the point? So, in 1998, there was a consensus group that came together to look at molecular and biochemical markers for Alzheimer's disease. And there are a number of criteria for something to be quote-unquote a biomarker, but some of the things that came out was non-invasive, simple to perform, inexpensive, etc., etc. So, a biomarker. How about I set the stage of what exactly is a biomarker? As a scientist, really, I think the reason we come up with these new words is so no one can understand what we're saying. So, really, all quote-unquote biomarker is it's something that's indicative of something else. So it's a biological something that we think is indicative of something. So HbA1c, for those of you who are diabetic, that's a biomarker related to diabetes. Your blood pressure, that's a biomarker related to hypertension. And the reason we call it a biomarker is because it has a biological relevance. So HbA1c not only suggests whether or not someone has diabetes per recent guidelines, but you can also track HbA1c to determine how they're responding to treatment. Alzheimer's disease, there's been a tremendous amount of work looking for biomarkers. So it was discussed in other talks, the diagnosis of Alzheimer's disease. How do you get a diagnosis? It's actually quite complicated, and it's not a simple thing to do because you need an expert. You need a physician who's an expert in the disease, so someone like Dr. Salazar, Dr. Royal, Dr. Esposito. So there's several. Here, actually, you're quite fortunate to have several experts in Alzheimer's disease and dementias in general. But I can tell you that there's a huge lack of expertise in dementia syndromes across the country and across the world. So why biomarkers? So one of the reasons is to help the diagnostic process. How does a primary care provider get someone to a specialist? The primary care docs, there's a huge literature, and I mentioned this earlier, that dementias, Alzheimer's disease, cognitive dysfunction, are common but undiagnosed in primary care settings. It has nothing to do with the primary care docs not being good docs. It has to do with they're looking at so much information, so much broad-based information, and cognitive disorders are simply difficult to detect. So what has been a huge push has been the brain scans. So can we do a brain picture of one form or another and get a diagnosis, or at least say this is who needs to get to a specialist? There's been tremendous work in this area, and neuroimaging is incredibly accurate at identifying dementia syndromes, at least certain ones. And now we have PET scans that can pick up the plaques in the brain. And more than likely in the next couple of years, we're going to have PET scans that can pick up the tangles in the brain as well. Those are already being looked at. What's the problem with brain scans? They're really expensive, and you have to have access to the equipment. So an MRI, for example, is not the best first-line screen. So let's say I've got a busy primary care practice, a geriatrician, and I've got several hundred patients. How am I going to get every one of those patients an MRI? And then how the insurance company is going to be able, how can we afford this? It's just not a cost-effective method. That's why MRIs are the second step. So if someone gets a head injury, normally they're going to get a CT scan in the emergency room, and then they're going to follow on to an MRI. So an MRI is a good confirmatory diagnostic. It's the more expensive part. Another way of a biomarker is through lumbar punctures. Now, women, any of you have kids? Yeah. So many of you had an epidural. And most of you wouldn't volunteer to just go have another one just for the fun of it. So LPs, lumbar punctures, are quite difficult because in our country, not every country, but in the United States, it's not very simple to just go get an LP. You don't walk into any clinic and get an LP. And if you do just walk into any clinic and they say they'll do it, you need to find another clinic. You want to make sure they know what they're doing. So doesn't increase access to care. Now, specialty clinics are very good at them. I know for a fact there are several people here that can do them and do them quite well. But again, not a first-line screen. So we've said bloods. The ideal candidate would be blood, and there are examples for this. So how do you get to a diabetes specialist? Your blood markers of glucose and HbA1c and whatever else gets out of whack, and you get sent over to that diabetologist. How do you get to an oncologist? Your CEA levels get out of whack. Other things get out of whack. Then you get a PET scan. You get to that. You get screened by a blood test. Same thing goes for cardiology. You get screened by a blood test. Most people think that blood test for Alzheimer's disease will never happen. However, what we've suggested is, all right, so we have to look because there are 40 million Americans 65 and above right now. 15 million more turning 65 and above soon. So we have to have a means for primary care providers to have something to know who to refer on. It's not to diagnose, it's a screen. First step in the screen, same that we have for basically numerous examples in the medical field. So what we have that are fantastic biomarkers, they do work, are expensive, there's a lack of access, and there's just no way you're going to do this as a frontline screen. So what we think is a blood-based marker can be the first step with screen positives going in for the follow-up. So they're more cost-effective, readily accessible, non-invasive, etc. Now, the other thing about this isn't just that they can refer for treatment or refer for confirmatory diagnosis. Those of you who have been involved with clinical trials, if you've ever been involved with a clinical trial for cognitive aging, you know that actually it's incredibly expensive to get patients into an Alzheimer's disease trial because of all of the steps to get in to confirm the diagnosis. The other thing is we only get patients from specialty clinics. Well, if we had some way for the primary care providers to refer in to clinical trials for the screening, it would actually streamline clinical trials and open up patient pools so that we can have broader access to clinical trials. And this is what we do with cancer, etc. And this goes back to what I mentioned earlier. Mexican-American patients rarely go to specialists. They're seeing primary care providers. They're seeing the nurse practitioners. They're seeing the physician's assistants. They're not going to the specialty clinics. So what are some uses for our blood-based markers? So diagnosis is what I've been discussing, but I'm going to discuss other uses as well. But then there's also those subgroups, quote unquote. So I can tell you right now, we have a clinical trial ongoing and I'm never going to see a patient. I have samples from a previously conducted clinical trial, and I'm using blood-based biomarkers to go back and reanalyze, quote-unquote, failed clinical trial that cost the NIH millions of dollars, because we think we can identify a subgroup of patients who probably got better in a trial that's deemed a failure. So you may be able to identify these subgroups of which patients perform. That kind of sounds familiar. So if any of you have ever gone to your doctor and been told, your cholesterol's bad, I can tell you, Dr. Salazar goes in and tells someone their cholesterol's bad. He's told them nothing. Okay, thanks. What's bad? Is it cholesterol? Is it triglycerides? Is it HDL? Is it LDL? Your cardiologist is going to tailor your treatment based on what's going on. We think the same thing can happen in Alzheimer's disease. Biomarkers of risk. We have pilot data now suggesting that the blood profile of disease presence is very different than disease future risk. So that if there's a blood profile that says someone's at risk for Alzheimer's in the future, that profile is going to look very different than a diagnostic profile, which is exactly what cancer has already demonstrated. Treatment responders, potentially, progression, etc. So here's kind of the goal. You do a blood screen, you assay, and so that's your screening piece, and then you just refer on. So this is basically primary care right here, because pretty much anyone anywhere can get a blood draw. So what have we done? Is this science fiction is basically what many of my colleagues have told me over the years. So you've heard this already. So what we've said is we're going to take a different approach to an old problem. There's no such thing as one thing in the blood, in my opinion, that's going to tell someone has Alzheimer's disease. But I firmly believe there's probably a profile of what Alzheimer's might look like from the biology. So we started off with that background. We analyzed 108 proteins. So this isn't a small set. Now, it's also not a large set. Some of these can measure several thousands of markers. But, so basically what we did was created a profile, biomarker by itself, and then age, gender, education, ApoE4 are really your biggest drivers, or at least risks for the disease. So we said, all right, well, how does that help in the profile? And basically, we're 91% accurate with the 108 proteins by itself. Clinical variables, but when you add them together, you're 95% accurate basically at identifying those who have and don't have the disease with the blood test. That's the pretty picture. Straight up, straight across would be perfect. So as you can tell, it's incredibly accurate. So we said, okay, 108 proteins, probably not all that cost effective, because that particular company we work with for that test would be, right now, it would cost about $1,000 a person to get. Now it's more than 100 in there. We just use 100, but still not very cost effective. So we said, let's narrow it down to the top 30. Also, I mentioned earlier the cardiovascular issues. Can they add to the approach? Again, you go to the biomarkers by themselves with 30 markers, we're 91% accurate, and we combine biomarkers with everything else, we're 94% accurate. So again, this is the one that works best. But then again, just the blood markers by themselves work really, really well. What's next? So this is where no one prior to us had ever taken it and cross-validated independently in a different study, not using the TARC samples, but in a national sample. And 88% accurate. This is your lumbar puncture percent accurate. So we're incredibly accurate with a blood test. So I'm going to take a bit of a tangent and tell you about some newer work that actually isn't published yet, and it's not in here. So what we've done now is even refined it further. So that was with a source out company, basically. Someone who would be a reference lab, where you send the blood to them, they do the assay, send it back, and you do well. Probably not for this particular type of approach a good idea. Having a single reference lab to do blood screens for anybody who wants to do a blood screen for an Alzheimer's disease potential, probably not a good idea. So we wanted to know, can you use a different approach to measure the proteins? So we took a platform, it's a particular type of way of measuring the proteins that, as a matter of fact, I know there's at least one of these equipment, one of these imagers in San Antonio. I think there are about 2 or 3. So every pharmaceutical company on the planet has one. So any lab can do this. So that's the real test, is can someone set up their own lab to do it? We narrowed it down to 21 markers. We're 98% accurate with 21 markers. We can actually narrow it down to 8 markers alone and still stay 98% accurate. So very, very exciting that you can narrow it down to that. Now we're down to around $100 a pop. That I can live with. That's something we can work with. Because if you go higher volume, price is going to go down. So it's something, at least a good starting point for clinical implementation, potentially. The other piece that we've done was, I get it all the time, well, if you're measuring it in the peripheral blood, has it anything to do with the brain? Really? You know, how can you tell me that if you're measuring it in someone's blood, it has anything to do with the brain? You need to validate it in the brain. Fine. So what we did actually, instead of just validating in brain, we decided to validate it in brain tissues of both mice and humans. And using the same approach, we're 100% accurate at identifying brain tissue as coming from either diseased or non-diseased, whether they're mice or humans. And the reason we know the mice have Alzheimer's is because we gave it to them. So you know, they don't develop it on their own. So then we took it a step further and said, why not in the periphery, in the peripheral blood tissue serum? Again, using the same approach, 100% accurate. So we've now validated this approach. Not only does it work in humans, we've refined it, but we've actually shown it's comparable to what you would find using brain tissue across species. So it's very robust. The other thing that we've taken now is if there's a profile of Alzheimer's disease, shouldn't there also be a profile of, oh, say, Parkinson's disease, or Lewy body's dementia, or frontal temporal dementia? So we decided to test that. We looked at same 21 proteins and took 203 people. Parkinson's disease, Alzheimer's disease, frontal temporal dementia, Lewy body dementia, Down syndrome, because most people with Down syndrome live long enough to develop Alzheimer's disease, and normal controls. Using a profile approach, we're 100% accurate at separating out who has what disease. Well, that's really promising, because if you're a primary care doc, and you have some way to say who needs to be referred for neurological issues, neurodegenerative issues, not only who needs to be referred, but who do you need to refer them to, that has tremendous potential. So we're pushing that on a little further, pretty excited about it. But like I said, it hasn't been published yet. And that's why it's not in here, because there are issues with presenting data that hasn't been published. So, back on track. How does this work? Support or not support the need to study the disease by different ethnic groups, and us again focusing on Mexican Americans. So why might ethnicity impact these biomarkers? So metabolic risk factors. We discussed this earlier, if I recall correctly. Midlife, obesity, etc., right? Well, okay. I said also earlier that midlife and obesity, adipose tissue, fat tissue, is an inflammatory organ itself. It's also related to increased inflammation. Oh, by the way, TNF-alpha is one of the top markers in our blood test. CRP is in our blood test. So, okay, if these metabolic factors vary by ethnicity, will the prevalence of the biomarkers themselves of the disease also vary by ethnicity? Same thing here, diabetes. Diabetes changes by ethnicity, but we've also found that you have links to inflammatory issues, prothrombotic issues. So diabetes is intimately related to a number of underlying biological changes that are also linked to Alzheimer's disease. So this looks familiar, I would assume, except for those of you who are sleeping. Then there's the, so the metabolic risk score that I presented earlier. So this is a clinical version of it, right? So this is just demographics, yes, no, yes, no. This isn't me testing the biology. But from this data, it says metabolic issues are more important for Hispanics than Mexican American in particular, than non-Hispanic whites, right? Here, I go back to the same that I presented earlier. This is a schematic of risk factors associated with the disease. Here's the risk factors that we showed earlier, right? And here's the relative weights for these different factors. here's the relative weight among Mexican Americans as we interpret the data, or as I interpret the data as it currently stands. So let's look at the data on some of these markers. So C-reactive protein, some of the data that I showed earlier. So C-reactive protein is a cardiovascular risk marker, okay? It's shown elevations in C-reactive protein are risk for future risk of cardiovascular insult, cardiovascular disease. This is a way of, it's an acute phase reactant, but it's a way of getting an inflammation. So there's recent data. So here's the dilemma with this stuff. Midlife high in this biomarker increases risk for Alzheimer's disease. Okay? So midlife elevation, increased risk for Alzheimer's disease. Now, here's an interesting piece. Just ignore this piece for a second. Then why in the world would normal controls have higher levels of C-reactive protein? So in Alzheimer's disease, it's actually decreased in disease presence as compared to disease risk. So the utility of this marker completely changes depending on where you're looking at the patient, right? So elevation midlife, increased risk for vascular dementia, Alzheimer's disease. However, what the Rotterdam study showed is that 5 to 7 years prior to diagnosis of Alzheimer's disease, there's no difference between Alzheimer's, the people who are about to develop the disease, and normal controls. So our thought was, all right, so this biomarker changes with time. It's increased risk, high midlife increases risk. As you're getting closer to the disease, the marker actually comes down, and then it declines. So lower levels are increased risk. And that's exactly what happened when we look at normal controls, MCI, and Alzheimer's disease. A steady decline in C-reactive protein levels, which is quite fascinating. So what about looking at it by ethnicity? There's a large literature already in place suggesting that C-reactive protein, this particular marker, is elevated among Hispanics and not higher among Hispanics and non-Hispanics, and that's largely due to diabetes and obesity. It's already there. But here's the interesting piece. It parallels. So you just have a higher level. So non-Hispanic whites, there's a stair-step decrease between normal, MCI, Alzheimer's. Normal, MCI, Alzheimer's. Fascinating. So it does decline. So it's a biomarker of Alzheimer's disease across ethnicity, right? No. It does decline just as it, so it looks, the profile of it. However, this marker is related to poor functional outcomes among non-Hispanic whites. It's not related to functional outcomes among Mexican Americans. So in terms of a treatment marker, it may not be all that useful. However, among non-Hispanic whites, it actually may have some utility. And this is explicitly the marker, one of the markers, when I said we're looking at a drug trial right now. It's among non-Hispanic whites who are in an anti-inflammatory trial. We're going to determine, does this marker at baseline tell you who got better and who got worse? This marker, same trial, if we had Mexican Americans in the trial, my guess is it would be useless. Now, so that's one marker. What about the profile of the disease? How does the profile look? And how does that impact the Alzheimer's disease blood test that I think needs to be in the hand of primary care providers? So we started, our first look at this actually just came out in 2013, Journal of Alzheimer's Disease. And this is what I showed you earlier, so I'm going to spend a little more time on this. So it's just a bunch of markers. You don't really need to, other than the psychology trainees, you don't need to memorize these. By ethnic group. And this is basically changes. So as disease is present, there's a different expression of that particular protein. But here's where it becomes very fascinating, and I hinted at this very briefly earlier. So the top marker here, thrombopoietin, is a vascular marker. Then you've got MIP1 alpha, TNF alpha, IL-10. These are largely, here's where CRP is, these are largely inflammatory and vascular markers. Pancreatic polypeptide, which is more of a diabetes marker, is way down here. that fits with the data that I showed you about the vascular risks being more predictive of Alzheimer's disease among non-Hispanic whites. Over here, on the other hand, fatty acid binding protein, CD40, GLP-1. This GLP-1 analogs are actually the field in terms of diabetic medications that's being pushed probably most heavily right now, are explicitly targeting that marker. And that marker turns out to be one of the most predictive markers of whether or not someone has Alzheimer's disease in this profile. The top 3 markers are all diabetes related. Actually, the top 5 are somehow related. Peptide YY, pancreatic polypeptide. Insulin is right here. This profile, from a profile standpoint, is very different than this profile. Okay? That has really important implications. However, we're still 88% accurate at diagnosing the disease with using the blood test. So the profile itself is still accurate. Can we improve it? Absolutely. Absolutely. And we've got some ongoing work that we think we figure out how to do that substantially. But this gives us confidence that using a similar approach, similar markers, just the profile of the markers are going to vary, we can still actually use this blood test as a screener in primary care settings. You just have to take into account who it is you're seeing so that you can interpret it. Well, that was mentioned earlier about the cognitive testing. If you've got you can have a great test, but if you use the wrong norms or interpret it inappropriately or you don't translate it correctly, it's useless. You have to take in the context. And there's actually discussions right now about changing HbA1c levels in terms of diagnosis and treatment for diabetes based on ethnicity. This is a new concept. This is something that's headed our way. So fatty acid binding protein, that's a pretty substantial fold change difference between groups. So and what's interesting is, so these markers, I've got check marks and stars, etc. So these markers have been found related to Alzheimer's disease across studies across the globe. So every starred one up here is related to an Australian study that came out. The checked one is related to overlap with our previous work. Yeah?
Is homocysteine present? I don't see that.
So homocysteine is not in our models. It is important. It is important. It just hasn't been entered in these models yet. So we are going to add homocysteine because homocysteine, as it turns out, is the backdrop from which you need to interpret, for example, testosterone data. So yeah, we're headed there. The reason it wasn't added in this one yet is I don't have the homocysteine data yet on all of the Mexican Americans. It's being run. So what's fascinating is this isn't something that's not replicating across the globe. These markers are consistently being identified in study after study after study. But what we've now shown is, yes, that's fine, but the relative profile of the markers themselves is important if you're going to try and move this forward. This goes back to the vascular issue, which then goes back to why these markers are so heavily weighted. The newer version of the blood test that I've done, that I mentioned earlier, we have that can be implemented in pretty much any lab. TNF alpha weighs very heavily. All this is from these same markers, so it's a vascular inflammatory profile. So, what are the implications from this? So, this is the key to me, take-home point, right now, that if we're going to design treatment trials, if we don't take this into account, we're just going to have more treatment failures. And that is, Alzheimer's disease appears to have a more metabolic profile among Mexican Americans as compared to an inflammatory profile among non-Hispanic whites. So if you want to do a treatment trial on an anti-inflammatory medication, which, by the way, we've already done 3 large-scale trials on this, and they've all been failures, you might want to enroll people based on their inflammatory profile. It's like enrolling someone into a cholesterol study and not checking their triglycerides or HDL or LDL, depending on whatever it is you're doing. The Alzheimer's studies that have done this before have not used these biomarkers to decide who actually goes into the study. Well, that might be why they failed. This is going to be very important as we design trials moving forward. This gets back to earlier what I said. This is what we've done so far. This is probably 90% of the trials that we've done in Alzheimer's disease, beta amyloid. And I mean, you can remove tau, it's just pretty much beta amyloid. We've done some in inflammation, we've done some here, more coming down the pipe here and here and here. However, if we're going to look among non-Hispanic whites and we want to do an inflammatory trial, here's where we want to focus if you want to go outside of the beta amyloid. Or if you want to look at multiple drugs, not just a single approach, well, more than likely, here's where you want to go. If we're going to look specifically among Mexican Americans, what the literature is teaching us is we want to get after those metabolic factors, potentially. And again, as I said before, in reality, it's not actually an ethnic or racial issue by diagnosis. It's a prevalence of risk factors. It's that the relative weight of these factors vary by depending on who we are and where we come from. We know this already. I mean, this isn't rocket surgery. Okay. So come on. Somebody. That's funny. I know I'm not a comedian inside. What should this teach us? Well, there have been many studies looking at diabetes medication for treatment of Alzheimer's disease, treatment of mild cognitive impairment, slowing progression from one disease to the next. You go to clinicaltrials.gov, here are several of the trials that are either ongoing or recently finished. There's an intranasal insulin study that's ongoing right now. That's, I'm talking to her, Suzanne, Dr. Kraft, about let's do that study among Hispanics because more than likely, it might work better. The issue, though, is I've not seen anything within Mexican Americans. So I mentioned earlier the Alzheimer's Disease Neuroimaging Initiative, ADNI. In terms of total number of people in the study, it's not the largest. However, it's the most comprehensive study of Alzheimer's disease in history. So everyone who goes through this has detailed neuroimaging. They have spinal taps. They have hours and hours of cognitive testing and interview, and they're seen longitudinally. So it is an amazing study. The last time I looked, there were 12 Hispanics in the entire study. So, it's a great study, and actually I'm friends with the PI. He's working with us. If we're gonna study this, we really need to start getting the minority patients into these trials. And there's previous literature to already support this. There's research on diabetes, and that race and ethnicity impacts treatment response to particular medications. Same in cancer, same in heart disease, et cetera, et cetera. So, told you I'd run through this one a little faster. Questions? Clear as mud.
Yeah, I have a question regarding, so you kind of clearly explained the biomarkers for, the different, kind of phenotypes, inflammatory. So, have you been able to split MCI from ADKs?
Right.
Specific kind of algorithm for MCI?
That's where we're looking now, because there's previous literature in ours to show that the biomarkers do change between Alzheimer's, MCI, and actually they change within stage of Alzheimer's disease. So blood profile of early stage looks different than late stage, even within Alzheimer's disease itself. So that's where what I wanted to start with was Alzheimer's disease. Presence, absence, get it to primary care providers. The next step is where we're starting now is how can we move it into MCI, but then how can we even move it pre-MCI and future risk. So those are the studies we're starting to design now. There's pilot data we're analyzing from the chart, but I'm also going to be running the markers that I already have in my lab on MCI cases, Hispanic and non-Hispanic, probably in the next, I'll probably run several hundred in the next few months. And so we will, definitely start. Yes?
I know, like in psychological testing, when you're looking at ethnicity and race, you may also look at acculturation, environment, and all that stuff. to kind of determine what norms you use.
Right.
With biomarkers, I mean, you've got somebody who's born in Mexico versus somebody who's born in Texas. You've got somebody who has 2 Mexican parents versus a person who maybe has a Mexican parent and an Anglo parent.
Right.
How does that all get worked out?
No,
we're kind of a...
It's a little difficult. The nice thing to me, though, about the biomarkers is I'm also one step closer to pathology. Okay? So cognitive testing, I'm one step further away. Actually, multiple steps further away. Because I have to worry about their interpretation of the questions. So the cognitive, I'm a neuropsychologist, so I firmly believe in cognitive testing, but it's several steps away from the biomarkers themselves. Proteomics is several steps away from genomics, right? The nice thing to me about the biomarker profile approach is that it allows us, in my opinion, I believe that these differences are actually what's driving the findings themselves. So that it is the cultural issues, it is the diet differences, all these things that underline the prevalence rate of the risk factors themselves. So what is it why are Mexican Americans at increased risk for diabetes? Well, I don't have to covary for that because I have the biological markers of the disease itself in the periphery. So that's what's driving it itself. So I don't have to covary for it because I can treat it. I can go directly at what I think is potentially underlying pathology. So I don't have to take as much of that into account. Now, do you have to consider it? Absolutely. So things like, was someone smoking before they walked into the office to get a blood draw? That'll spike your inflammatory markers. Female on hormone replacement therapy or on birth control alter some of these profiles. Dental issues. Someone who has really, really bad teeth, their inflammatory profiles go through the roof. So there's still a lot of issues that have to be taken into account. But what our data shows is that that's actually the robustness of a profile itself. Is that, yes, there are individual differences, but when you look at an overall profile, the individual differences get washed out because it's a profile of the disease. So what some of these studies do is they look at Alzheimer's patients versus really healthy, super normal controls. So the Alzheimer's patients have all kinds of stuff. Any of you who see Alzheimer's patients on a regular basis know that most of them have something in terms of either diabetes or high blood pressure or something else, right? And comorbidity is the rule, not the exception in Alzheimer's disease. The way the TARC study was established was to look at cardiovascular issues as they relate to Alzheimer's disease. So there's absolutely no difference between the groups. So this is a very unique place to study the profiles because it's not a disease versus non-disease group. So we have equal prevalence of diabetes across the groups, pretty much. We have an equal prevalence of hypertension across the groups. We have an equal prevalence of dyslipidemia. So it's a unique place to be able to study that. And then we take it to the other studies that are very, quote-unquote, cleanly characterized, and it still works. So for me, it's a profile approach that actually, it's more robust. And that's why I think other studies to go from one marker from one study to the next fail to replicate. Because they look at one marker that was altered in this one study because of some characteristics of the group. That will not alter an overall profile.
So you don't necessarily need to know how Mexican the person is.
Nope.
For lack of a better...
Right. No. At this point, I don't think I use age, education, gender, and ApoE4 in the algorithm itself just to increase the robustness of the, but so far we don't need all that data. I mean, because we're already 98% accurate. Could I increase it? I might go to 98.2. But, if I can be 98% accurate by doing 8 blood proteins and a couple of questions, I'm happy from diagnostic standpoint. Then they get referred to the clinician. Then it's the clinician's job to spend more time and figure out, make sure they're treating them appropriately.
I was just wondering if the comparative studies have been done with, because I know as a nation, we consume more omega-6 versus omega-3s in a higher ratio than they should be, of a 1 to 4, which contributes a lot to these inflammatory conditions that we're seeing. And basic, simple nutritional treatment, a change in diet to the Mediterranean or the paleo or whatever, can lower a lot of these without drugs.
I agree.
I mean, diet compared to drug treatment is about, what, $2,700 difference. So,
When you take the data I just showed you with the data I mentioned earlier about diet and exercise changing the underlying pathobiology of the disease, this data not only tells me we can look at drug trials differently, but it also tells me that behavioral, nutraceutical, other sorts of interventions, there's direct evidence of, from a biological standpoint, why they should work. Absolutely, I couldn't agree more. This supports more of those studies. It supports, this may help. One of the things that we haven't looked at with this is, can you use these markers to monitor progression and monitor treatment response? So that's where we're headed with it, because one of the problems with Alzheimer's trials is it takes so long to do one. So it takes 2 years to look at a true cognitive change, or at least 12 months, whereas a lot of trials you can be done in a few weeks. Alzheimer's trials are very complicated because of the time length. If you can have a biomarker of treatment response, you can shorten the trial, cut the cost in half, and all of a sudden you can move something along the pipeline. Any other questions? All right, thank you.
I'll leave the computer on for you, Trevor.
Good job again. Thanks again. Thank you.
Okay, ladies and gentlemen, we ended a little sooner than expected. That's okay. So, would you do me a favor, stand